Data analysis and predictive analytics are driving fundamental change in how hospitals and health systems provide patient care. In general, the more you know about high-risk patients, the better the chances of keeping them on the road to improved health. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. It's a classic win-win. Used effectively, predictive analytics is a way of employing patient data that helps enormously with proactive care management. It can help to avoid unnecessary readmissions, for example, saving both time and cost. Best of all, predictive analytics can help patients to better understand their own health habits and make good choices going forward. Grady Health System in Atlanta has been a leader in using artificial intelligence and predictive analytics to provide better all-around value for patients and providers. One patient has said that Grady's approach, quote, gives me the strength to be an active participant in my own health. In this podcast, Grady Health System's Chief Strategy Officer outlines the advantages and results of using predictive analytics with Julia Resnick, Senior Program Manager for the Value Initiative at AHA.
Hello, I'm Julia Resnick, Senior Program Manager for the Value Initiative at the American Hospital Association. This podcast series is part of the Value Initiative, which highlights how hospitals are improving value and affordability for their patients and communities. These members have implemented strategies that enhance the patient experience, improve quality, outcomes, and cost. In today's Members in Action podcast, I'll be talking with Shannon Sale, Chief Strategy Officer at Grady Health System in Atlanta. She'll be sharing how Grady is using artificial intelligence and predictive analytics to advance their population health strategy. Thank you so much for joining me today, Shannon.
I'm glad to. Thank you for having me.
Let's start with some background on Grady and your population health work. Can you tell us a bit about your community and your hospital?
Sure. As you mentioned, Grady is a large academic safety net hospital in Atlanta, Georgia. We serve over 60,000 people annually. That breaks down to, of those people, the visits are about 150,000 or so ED visits, 35,000 admissions, over 400,000 clinic visits. Our payer mix, the patients that we serve, their payer sources are about 31% Medicaid, about 28% Medicare, 24% uninsured, and about 17% commercial. So we have a wide variety of folks that we serve, but mostly either government or unfunded from a payer source. We have one of the largest hospital-based EMS or ambulance programs in the country. We have 6 neighborhood health centers. 5 of them are primarily primary care. The 6th is a comprehensive care center. We have a dedicated infectious disease program where we treat about 25% of the population who have HIV in the state of Georgia. We have a 24/7 sickle cell program. And then we're known for our trauma, stroke, and burn programs, those kind of highly emergent services, and are building population health to kind of balance that out. So looking at the needs of the population in the primary care and clinic setting and how we get ahead of managing their health overall.
So as you're starting up your population health strategy, what was really the problem you were trying to address?
So given the broad nature of the population we serve, we have a high demand of services for a limited supply. As I mentioned, we are a safety net, and so our reimbursement models are pretty tight. And so we wanted to have a robust risk stratification process to help target the services where they were most needed. And so as we developed a high utilizer program in the emergency department, our diabetes program, our chronic heart failure program, we wanted to make sure we were getting the right resources to the people who needed them the most.
And how did you come to realize that AI and predictive analytics could help support that work?
So our care management teams mostly were using kind of the assessment tools that were out there, asking 5 or 6 questions either around socioeconomic or other clinical, but they were pretty basic, I guess, and really didn't help. Everybody had a really high score based on the assessments that were out there. And so we started to look at, as we started to expand our programs, we wanted to make sure, again, that we were targeting the right services to the right people and the right interventions to the right people. And so we really our IT group said, well, we have a lot of data. We've had Epic since 2010. Why don't we start to look at what we can do with the data? And so we had a broad RFP process where we looked at a number of vendors. We narrowed that down to 3, and even through that process, we learned more and more of what we could do with data. And we found that there were companies using data in healthcare just like they were using on Google or on Amazon, or we're taking data and saying, okay, what does the person want or need next? And so using that in healthcare, they pulled in both. We found that they were pulling in, the company we selected was Javion, and they would take our data for 3 years, pull in both the clinical and socioeconomic information they had, which was really based on address, zip+4, some of the indicators that we were asking, whether it was their financial status or their percent of federal poverty level. They were using that data to begin to help us to determine kind of those folks who are at the highest risk.
Mm-hmm.
So we started to, as we kind of got through that process, even through the RFP, we began to develop the use cases that we thought would be best to align to the population health initiatives that we were putting in place.
So what were those use cases?
So the first was highest risk for readmission. And that was really focused on the inpatient side. And then we began to look at diabetic care, chronic heart failure, and ED, the risk or the chance that the person was going to come back to the emergency department or use the emergency department in the next 30 days.
That's super interesting. And so how has using AI changed how you provide care to your patients at Grady?
So particularly on the readmission, I'll start with that one. First started with the list, taking the data, we created that risk of the highest utilizers, so red, yellow, green. And so we looked at the folks who were red or had a risk score that put them in the red. And we applied, we would send that list to our mobile integrated health. As I mentioned, we have a large ambulance service here. An offshoot of that is our mobile integrated health, where we'll send a non-ambulance, like an SUV, to a patient's home as a follow-up. And so this list from Javion initially drove their work. So they would know who had been discharged from the hospital, who was at highest risk for readmission, and we'd send a team, the mobile integrated health team, to them in the days following their discharge from the hospital. That grew into our transitions of care program. And so specifically, again, low resource hospital, hard to have as many navigators as we need, but the navigators could use that risk score and know when their patients in the hospital, go have that targeted list, go meet with the patient, and specifically help to get them an appointment in our transitions of care clinic within 7 days of their discharge. And so that became a really big, that became probably the biggest change of our workflow, of having that navigator group being able to expand it, because we were able to say, we have this many patients, these types of patients who need that navigator support, and then connecting them back to a transitions of care clinic center, but clinic environment, where then we could help the patients post-discharge with medication management, any follow-up instructions, other support that they needed post-discharge.
Yeah, and that's just a really great way of targeting limited resources for where it would have the greatest impact, and really interesting to learn about. So I guess speaking of impact, all of us do what we do because it has an impact on the patients and the communities that we're serving. So what have you been seeing as the impact from using predictive analytics?
So initially with our mobile integrated health team, we saw, we were at the highest risk patient. Again, we saw a good outcome of readmission, a reduced outcome of readmissions into the hospital. And so a lot of benefit of that program. That patient population had a higher expectation of being readmitted. So the readmit number might still be high comparatively, but for that population, it has come down a good amount. Conversely, it's not negative, but by engaging, again, this high-risk population, in some cases we have seen utilization go up because they needed it. So they weren't getting the care before, but now that they have this team and who can identify what their needs are, in some cases we have actually seen some of the utilization go up for either inpatient or more outpatient. Across the board, we have seen when we target the high utilizers in the ED, their ED utilization come down by about 44%.
So I'm sure that this has all been a significant learning experience for you. So what are some insights or things that you learned over the course of implementing this AI predictive analytics work into your population health strategy that you could share with others who are thinking about heading in that direction?
So, of course, data is powerful. That's to state the obvious. We have found that being able to have that access, that extra layer of information, has been really helpful. And I would even look back 5 years and say we were really flying. We were identifying what was right in front of us and connecting an intervention there and hoping that that was the right thing to do at the time. And so I think now with this risk score, we were able to target and use that data in a powerful way. We also have learned that it can be hard to change behaviors even of our clinical staff. So trusting the data is another curve that you have to get over. Being able to show folks that, yes, here's a risk score. I'd say one of the things that is more than just a score that we have with the JVM product is when you hover over it within our electronic medical record, it tells you why they score that way and what the social conditions are, which I think helped on particularly on the clinicians who might have thought, well, I've studied a long time, I've done this for a long time, I don't need a risk score to tell me. There's an added level of information there. And so continuing to work through kind of the way people have done and known in the past, particularly from a clinical side, how to get that data to a digestible format into a system that is more supportive and certainly isn't telling people, forget what you knew, just look at the score. It has to be a blend of that, of what physicians and other clinicians know and how this helps to guide them. And then I think ultimately that it is the right mix of this high tech and high touch intervention. And so the data helps you to know, helps to guide you with what you need to do. It can't work, and we learned this early on. We had the data, but we didn't have anybody to connect with it. And so that high touch, whether it's a navigator, or a community health worker, or a social worker, has to be in place and has to have kind of that right interaction with the patient to make it meaningful.
Mm-hmm. Yeah.
To help us to have the right outcome.
Yeah, really connecting the human and the technological side of things.
Yeah.
So what's next for Grady in this space?
So with the Epic upgrade that we just put in place a week or so ago, we'll be able to document the social determinants of health. And so while I mentioned before, we're using really the zip code and address and other kind of what we can get in the electronic medical record, being able to document specifically social determinants of health around food access and housing and transportation and literacy and just general support from whether family or friends, having that documented will help us to feed the machine learning even more. And so we're looking forward to what that helps us to guide and refine both risk and interventions. And then within that, we'll also be able to catalog the interventions that we're doing. Historically, we took the number and we had an intervention, and you might have it in the notes, but it wasn't somewhere that we could put it into the machine learning. And so being able to catalog those interventions will only help us to be more confident or use the information we get back out of the machine that will be better in the future or just continue to develop in the future. So that's tied to the current use cases. Recently, we're moving into some of the clinical side as well. So predictive analytics around pressure ulcers, potentially falls. As well, we have a separate system that is helping us with potential for sepsis. And so that would be, again, more on just the clinical side, but using the data that we have to help to predict that and improve patient safety in the hospital will be a key element of how we use these systems.
Oh, that's all really exciting work, and it certainly sounds like integrating predictive analytics into your population health approach has had a significant impact on the health of your patients. And we really look forward to hearing about how that work continues to grow. So thank you so much, Shannon, for joining me today and sharing this important work. It's truly an excellent example of how hospitals can redesign care delivery to improve quality outcomes and the patient experience.
Okay, thanks.
For more podcasts and additional tools, resources, and education to help you promote value in your community, please visit the Value Initiative's website at www.aaha.org/thevalueinitiative. And this concludes our discussion for today. Thank you so much for listening.